Now we have Dr. Shamanth Shetty, who will be talking on decentered IOL and IOL tilt. Over to you, Shamanth.
Thank you, Dr. Vikram, and thank you, everyone. Thank you, AIS, for this opportunity. So I'll just talk about decentration and IOL tilt, which happens here. Basically, it happens because secondary to a complicated cataract surgery. A main cause for IOL tilt is for our capsular fibrosis, IOL haptic positioning, suturing errors during our SFIOL times, scleral positioning again when you're trying to planning for an SFIOL, haptic breakage, or you go undergo if the patient has undergone a previous retina surgery. Mainly, and decentration occurs during your surgery when you attempt, like you have done a very large rhexis, zonals are weak in one quadrant, you have not identified a PCR, one haptic is in the bag and another sulcus. Days or weeks you notice again the lens being displaced because again in a spontaneous IOL, especially in your torics, it is malrotated because because of your zonalizations. Months or years, again in case of trauma, pseudoexfoliation or in Marfan's. So what happens is this 1 millimeter of decentration or your 5 degree of tilt, this basically results in your defocusing, your vision quality decreases, and there is aberrations which are formed. So this affects is like if at all the patient has little bit of large pupil, the effects on glare, starburst, double vision, these are all are present there. So how do we like evaluate the decentration? So we have to see like what is the degree of decentration, symptoms, and the accompanying complications with that. Mild if the optics is covering more than half of your pupillary space. Moderate decentration if it is covering less than half of your decentration. Subluxated if it's already one half is in the pupillary space. Luxated if it's already down. Symptoms mainly, as I said, your vision quality decreases. Glare again is related because of your IOL haptic causing again monocular diplopia, floaters. Complications include your inflammation, your IOP is increased, vitreous incarceration, red CME. So how do we measure this? Mainly like the simplest is like when we are operating the microscope, like we see the light reflection, that is better to focus. So that gives you like a invariably like it's simple, but the right reflection gives you a fair amount of idea how to go about it. Ultrasound microscopy gives you a clear idea about the tilt and the decentration, but when you are it is basically again you are going to use a contact method. So this might again deform the eyeball, which will give you a wrong result. Sheen plug is very fast, it gives you an accurate result, but you need what happens is you will need to dilate it, and you will need a more than 6 millimeter pupil to get a good correction. ASOCT, which is again the non-invasive and non-contact imaging, gives you a tilt at the horizontal direction and the vertical direction correctly. So all the newer generation OCTs automatically will give you a view of it. Eye trace again is based on your ray tracing aberrometer. It's the combines both your wavefront and as well as placid based. So this in your higher order aberrations like glare, halo, which cannot be quantified by refraction is got here. Modulation transfer function, which is there in that, it gives you a clear picture of an entire optics of your eye. So that differentiates and gives you what is happening in the cornea, or is it the problem in the lenticular part. So if at all, like how we are seeing here, we are seeing up, like we are seeing the amount of astigmatism, the amount of aberrations which is there. So we know, like again as we see here, this is how much of amount of the refraction which is left. So best way is like when you expand it off and put another lens there, all these things are cleared off. So how do we manage it? Basically you can start off by giving glasses and you just try to observe it, and if the patient rejects, then you can plan for something else. So when do you want to intervene it? You need to see again like how much it is decentered, what are you going to do, and like if at all it is going to keep this going to happen, how are you going to manage it? So if at all in case of decentration, if you have already noticed a PCR, better again you do an anti-vitrectomy. If you are seeing the lens being already luxated, try to take it out, get a VR opinion, make sure everything is stable, and then go for your second plan. So again the outcome of all these things depends upon the pre-operative macular function, how much the complication is there and how much we can handle it, and the complication at the final end of the surgery. So mainly now we can start by try to reposition it, especially the torics. How much ever like within 1 to 2 weeks you are coming to know like how much it is rotated. So it is better that you intervene then and there. If at all now your lens is not placed in your bag correctly, you can try to go in then and there, try to place these things. Sulcus, if it already you are known that your lens is not correctly placed there. Bag placement in case of your capsular support devices if possible. Exchange, if the risk is like again you plan it when it is really bad, you have to go explain the risk of your corneal endothelial trauma, and again you are repositioning things. It's better that time you use your high risk exchange. When you are doing it, better to use again your IOL cutting forceps, cut it into correct halves and then take it out. If you're planning for an SF, make sure that you are making your point of fixation very correctly and markings. And again, when you're suturing, like how tight or how loose, you have to check it out. So summary, like evaluation management strategy must be planned. Do not inject your broken haptic when you're already seeing it that you can explant it then and there. Do not misjudge your IOL placement also. Decentration has a greater impact than tilt on reducing your visual quality. Proper placement of your secondary IOL also is very important. My take-home message would be negative negative impact on the optical performance and the patient satisfaction is equally important. When you have the availability of your excess markers and toric markers, it's better to use them. IOL decentration more than 1 millimeter or a 5-degree tilt has to be addressed. Visual performance of multifocals and torics are profoundly affected, especially in your premium patient when you use this in case of decentration and tilt. Yeah, thank you for your time.
Thank you, Dr. Shamanth. But a couple of points I just wanted to tell you. See, now the incidents of, I think, Sharath, you can plug your presentation. That before that, we need to have some discussion regarding this. Most of the people wants to go for premium IOL practice. So to have premium IOL practice, sometimes this decentration, when you see like post-operatively patient coming after 1.5 to 2 months, when you see the center part of that multifocal will be on the shifting towards the pupillary margin, you will see a lot of rings around. But you might be thinking that, okay, I have done the surgery very well, but why this intraocular lens has been decentered also? There are two possibilities. They might be having a larger capsule bag itself, and also they might be like whatever some people might have done under the block, where whatever once the eye is anesthetized, wherever it gives the Purkinje image may not be that true. These are the 2 points. But one equipment, no financial disclosure, really makes us so easier is eye trace. Because eye trace gives you exact value of angle alpha and angle kappa. So if you think that, okay, if the angle alpha is more than 0.6, then we better to avoid these premium intraocular lenses, because if you are having a large angle kappa, especially angle alpha, even angle kappa in hypermetropy, then the chances of this decentered IOL will be much higher. Rather, satisfying this patient will be much difficult. Again, there are one more aspect I want to highlight here. When you are going for any of these premium IOLs, okay, think that already patient angle alpha is larger. See for other eye also. Still patient wants, always you can play around with both the eyes. That means nowadays for any premium cataract surgeries, knowing the dominant eye of that particular patient is very important. Always you have to be dead on with the intraocular lens power calculation for the dominant eye, but non-dominant eye, there is some amount of any decentered lens or any more rings even in the pupillary margin. If you see, there will not be any much complaint by the patient, but you have to be dead on. That's why even I tried in my mother. One eye I put a monofocal on the dominant eye, and the non-dominant eye put a multifocal. Even she had a very large pupil, she never complained, because her dominant eye is very happy. She could able to see for distance. Always knowing dominant eye is very important. And one more point, lot of people have been tried with something unique lenses. My friend Dr. Sri Ganesh, he had been tried with something lens which can be glued within the bag. So some of the patient with a large angle alpha, when you put it, it is not corresponding with the Purkinje image. You glue within the bag and make it centered, which is, if you ask for any of the cataract surgeon, is the most difficult job in that time. Still he tried and he was very successful, gluing the IOL in the bag or in the sulcus. That also makes some sense, but it's all difficult. Again, decentered IOL is one big challenging. Of course, again I am telling you, if you are having decentered, again give the patient for 3 months, give for neural adaptation. If neural adaptation does not occur, then all this management is...
Yeah, you'll need to plan for the, like how to assess it. If the amount of decentration, especially, will not come to know. The thing is, like, if you're trying for your torics, it's better that you go then and there earlier, because later when you use it, your capsule becomes contracted. So that time when you go to rotate it or to handle it, it becomes problem.
Actually, I had a patient actually with the toric trifocal I have done, patient with a very high myopia. The biometry was perfect, but after putting these lenses, the lens rotated within the bag. Then what I did normally, like what David Chang say, that you have to keep the patient for 1 hour, then get in front of the slit lamp again, see, then you rotate. I rotated, then called the patient after 1 week. Again the lens rotated. Then I took the patient back into the OT. Then again it was rotated for another 1.5 cylinder. Then I said that I just kept quiet, but I kept the patient like for 3 months follow-up. Then he was quite happy for his near vision, and other eye was luckily the lens not rotated and I could able to get through. So these are the small problems I think you have to be very, very careful. I thank Dr. Shamanth for a wonderful talk. Yeah, there are different types actually to know the dominant type. When you have got, make a small aperture within both the hand. You put it around 636 in the Snellen chart. Tell him to see through the aperture through this thing. Then tell him to get this both the hands together. Then whatever the dominant eye only, you will try to focus. Then again you tell him to take back. You try to close each eye. When you closing the dominant eye, suddenly you will tell that I cannot see anything. Then when you closing the non-dominant eye, still he could able to see. That means you are checking the proper time. There are, even if you check where you are shooting test also, always you do through your dominant eye. You can try from here also. So knowing the dominant eye in every patient is very, very important. So in continuing with the unhappy cataract patient, we have all dealt with how we deal with the refractive surprise. I spoke about the laser vision correction. Dr. Vikram told about dysphotopsia is one of the complication which we can tackle them. Shaman talked about the decentered IOL and IOL tilt, and Dr. Sunil Galekar spoke about how you manage the capsule contracture. But there are other problems also for patients' unhappiness. Most important problem I think everybody keep in their mind is which is associated with the retinal